Okay, welcome everyone to our fourth session of our LC on the SDOH and its application. I'm Dr. Kevin Lombardi, and session 4 is the SDOH program design and workplace management aspect of our program. Thank you all for your service to your communities and your time dedicated to this subject today.
Hello, everybody. My name is Frida Pineda, and I will be assisting Dr. Kevin Lombardi on all the logistics that will happen today for today's session. So first, the mission of the National Center for Health in Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is also a national training and technical assistance partner. The information presented today are those of the author only. This is just a quick reminder to everybody that all participants are muted upon entry. Also, if you think your line may be unmuted, please make sure that your line is unmute. That way we don't have any interruptions throughout the presentation today. If you have any questions or any concerns today, or if you would like to also participate in some of our engagement questions that we're going to have throughout the session today, you can also do that in the chat. Raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and recording link will be provided to you via email after today's session. Now we'll pass it on to Dr. Kevin Lombardi.
So welcome again, and just to briefly go over these statistics again, the takeaways of this slide is our FQHCs serve an immense amount of people throughout the country. They serve an immense difference in different communities and immense diversity of people throughout the country. Our FQHCs that see public housing individuals living in public housing and those living in transitional housing are throughout the country. And we appreciate your service to this population and your consideration of their unique needs. Next slide. And our public housing demographics that we'll refer to throughout this presentation in LC. The important considerations here are the disproportionate impact of disability on families living in public housing and disproportionate demographics when compared to the US population as a whole. In particular, individuals living in public housing disproportionately identify as African American, Latinx, and as living in households headed by a single female. These are considerations that are important to bring into program design and patient care when seeing individuals and assessing their unique needs. Next, please. Today will be a practical session focused, grounded in literature and grounded in case studies. We'll discuss the process for institution of SDOH pilots, in particular, how to institute screeners and how screeners can lead the process of SDOH program implementation. We'll review the adaptation of screeners to community needs and the processes needed to do that, and also discuss the impact of SDOH policies on burnout and employee psychological well-being and ways that that can be managed at both the health center and employee level. Thank you. To ground us firmly in the framework before we start, for those of you looking for an exciting morning read, I'd recommend picking up the conceptual framework for the action on the social determinants of health. It's for those of you who understand things or prefer to understand things more on an academic level. It's very detailed and very thick, but has a lot of actionable things that can help increase your understanding of the global perspective of SDOH and how everything we do is in many ways tied to things other countries are doing in this respect as well. Next, please. And of course, the diagrams that we've seen many times. This is to indicate that these diagrams are great ways to conceptualize the unique needs of individuals when you see them in the exam room, but they are frameworks. that are very general. When you're looking at these and considering these, adapt this framework and things that it covers to the unique needs of your community and the unique needs of your patients. Next slide, please. We're going to start with a case study designed to elicit both patient and institution needs and to discuss those needs in the context of the literature and the changing dynamic of how SDOH is part and is being implemented more as part of health center management and patient care. So I'll read the case study and we will have some questions, and I'm looking forward to hearing your answers and your insight to how these things can be changed, improved, and how we can change and improve our own actions with our patients and at our health centers. Mrs. Wilson is a 54-year-old female with a past medical history significant for type 2 diabetes, stage 2 kidney disease, and depression. She presents in the ED with complaints of frequent falls. When Mrs. Wilson enters the ED, she is processed by the intake nurse. Vitals and intake are performed along with an SDOH screener. She is sent to an exam room and receives a complete physical and laboratory examination. Results indicate persistent low-grade tachycardia and mild hyponatremia. Review of past medical history indicates similar occurrence happened in 2017. Mrs. Wilson is diagnosed with syncope and told to follow up with her PCP in 3 days. No changes to her medication or other actions are taken. Next, please. One week later, Mrs. Wilson is seen in the same ED, for a head injury. During her physical examination, she mentions that she frequently feels dizzy, falls 2 to 3 times per month, and that alterations in her medication have not altered this frequency. Due to scheduling conflicts, she was unable to see her PCP since the last visit to the ED. On closer questioning, Mrs. Wilson mentions that when these instances occur, she feels overwhelmed and loses control of her body. Mrs. Wilson is admitted to the hospital where she spends 3 days as her electrolytes stabilize. She receives care for her head injury. She is seen by social services inpatient, who again perform an SDOH screener. Before discharge, Mrs. Wilson is again seen by social services, who are performing her discharge planning and final linkage to resources for when she leaves the hospital. They networked her to services during a 20-minute consultation. The screener is performed again at this time. Next slide, please. Please consider the following question. In her examination by hospital staff, Mrs. Wilson underwent multiple SDOH screeners. Considering the case, how do you think this impacted her? Were there areas of hospital workflow that could be altered to ensure a more judicious use of SDOH screeners? We will take 3 minutes to review the case and to consider our answers. Please make use of the chat if it's convenient. And my recommendation would be to type or to write it in some way. We'll take hands and respond to the chat in 3 minutes. Thank you for your time and participation, and I'm looking forward to hearing your opinions on this case. Fide, as we're going through the case, could you cycle through the first and second slides so our participants can see the details? Thank you. Just the 2 slides. Yes.
Let's see the client.
Mhm. And for those of you who work in social services or are in direct patient care, I'm very looking forward to your thoughts on this. And for those of you who manage programs, I'm looking forward to your thoughts on the management structure of this institution. We're going to take just one more minute. For those of you putting things into the chat, if you see something that is the same as the response that you'd like to enter, please go ahead and enter it as well. It's helpful to see the trends in what folks are saying. Thank you. Okay, 20 seconds. And Fide, after this, before coming to the responses, I'll review the case in detail.
All right. So now I'm gonna ask Susan Adams, if you would you like to add a little bit more onto your response?
Hi.
Hi, Susan.
Hi. I know for my understanding with patients with the SDOH, they're already kind of keeping it close to their heart and answering these questions in the first place because a lot of them are very personal. So asking them multiple times throughout a single visit or on multiple times through multiple visits is kind of like, why is there not a system to this to them? Why do they keep asking me this? They become frustrated and overwhelmed. The second part of it is, if you're asking these questions, especially her initial ED visit, what was done? Because I don't see anything noted here that there was any like response to her, anybody following up with her. So I don't know if that just isn't in here, if it didn't happen, but that's an important part, is the follow through on it. And then that could help negate constant questioning on this, because then it would be documented that she was getting help and they could be checking to see how that help was going instead of asking her the same questions over and over again and not doing anything with them.
Yes, so you nailed it. This case is based on the structure at a community hospital that I worked at for a number of years. You nailed it with the frustration and the patient's perspective of this. If we're looking at this case from the patient perspective, like we're looking at very difficult things. We're looking at someone who is experiencing severe SDOH strain on top of very serious chronic diseases. And dealing with a chronic disease on a daily basis is very difficult, as many of us know personally and professionally. ED visits make that a lot worse. It's very difficult to do SDOH screeners in ED visits. And if we do it, we need to make sure it has actions behind it, because that frustration is a very real thing. One could imagine if they had an SDOH screener at a time in their life when they're in the ED, that would add a lot of stress to an already extremely stressful situation. And that sort of highlights the need to be judicious with the screeners. So I agree and appreciate your input. If I may ask, do you have a responsibility that's related to patient care directly or indirectly?
Yes, I am the chronic care coordinator and care manager, and that's my main job. I'm an LPN here in addition. and we wear multiple hats. So I also deal with all of our CGM patients for continuous glucose monitors in depth with diabetes and hypertension. So those chronic conditions, in addition to the care management side, and then the ones that maybe don't have as many conditions to qualify for care management. So I'm asking a lot of these questions regularly because we have found obviously the link to if they're not taking their medications properly, or if they're not having help at home, or they can't see their medication bottles, or they don't have food, or any of the things that fall into those SDOH categories. As soon as we get some of those things straightened out and have that hierarchy, like Maslow's hierarchy, met, then we tend to have a better outcome in what's going on with them, because sometimes they're afraid to ask for help. And we put this form out there. That's why it frustrated me when I read this case, because I'm like, it's hard for people to answer these questions. I watch them struggle with their pride, especially our golden generation. They don't want to ask for help with anything. They can take care of themselves. They believe very much so, but sometimes we all need a little help. And as we get older and other things start to decline, our vision or, mobility or whatever, and then you have these health issues also tugging at you, it just makes all of it very overwhelming and needs to be, touched on. If they share that information with you, you need to feel privileged to have that information and do something with it to try to assist them or explain someone who could, or why you're not able to help them without they need an answer.
Susan, when I remember in my first year of residency, I did my residency in a rural community in the south of Virginia. And I had a patient who was 84 years old and still took care of 100 head of cattle by himself with his own hands every day. And this was a man who needed some assistance in some ways. And it required a lot of navigation to be able to meet his communication needs. This individual was someone who was used to doing things by himself and did not like asking for help. Just filling out a screener for someone like that is very stressful. In some ways, it may go against something that's very personal or very important to them. If you don't mind, could I ask you a follow-up question about what you just said?
Absolutely.
So you mentioned the patient frustration, and it's something I've observed in my own practice. And I was wondering, how does that manifest when you see patients? When they seem frustrated, can you tell? And how are the ways that you can tell?
Body language, if you're watching them when you're speaking with them and carrying on a conversation, like, I don't know, when my patients are here, I try to carry on a conversation like I would with anybody else in a professional manner, but also, caring, empathetic, sympathetic, all of the things that need to be there. And if you're watching the body language, sometimes you'll see like anxious behaviors like foot tapping or twisting hair or doing different things like that, or like disengaging in visual contact with you, or I've had patients that I've watched in our facility get up and just walk out of something. So it just kind of varies, but that body language, eye contact, and those things like that are the biggest ones.
Yeah, that's a lot of human emotion behind those things that you said, that body language and the individual walking out. I can't imagine what they were going through. And a final question, if you don't mind, has there been anything in your own work that you've noticed helps with that?
I was taught a long time ago a process called LAST, and it was used in a different type of work environment. I worked in grocery, and we called it listen. Was it listen, assist? Shoot, someone just popped in my office, so it made me lose my mind on it. But listen, apologize, satisfy, and thank is what it stood for. And so I've tried to kind of implement that in a little bit different way here, where I listen, and the way they know that is I repeat what I'm hearing from them. So I'm understanding this is your problem. That's how I'm letting them know that I am listening. And rather than apologizing, I'm using the A for assist here. Like, how can I assist you? What I'm hearing is I might be able to assist you with this. Satisfying, I try to go through and be like, is that something that you think will work for you? And then I thank them for the privilege of being able to work with them.
Wow. I think that's a really thoughtful process. Physicians are rarely from the communities where we practice or where we train. I think there's room for more appreciation of the social skills and understanding that go behind your work. Thank you for your time, and thank you for your insight.
Thank you for asking.
Fide, if you don't mind picking another.
Yes, of course. And Susan, do you mind sharing with us what health center organization you're joining us from and what state?
Oh, absolutely. I am with Adams County Health Center in Council, Idaho. We're an FQHC here in rural Idaho. Our population for our city is a little over 900. And I think our county is like 35 or 3,600. So we have a great golden generation community that I love caring for and being here for.
And thank you for your service.
Thank you.
All right, now I'm gonna choose George. Would you like to participate verbally?
Sure, that would be great. Thank you. Gathering SDOH data throughout a patient's stay in a hospitalization, I think needs to be specific as to the timing of where that patient is at. As they come into the ED, their presenting problem obviously is the priority, and gathering data around how that problem may have occurred is important. So I think that SDOH data, I agree with, I think it was what Susan was talking about. When she says it's frustrating when nothing was done with the information. I think it's, again, looking for relevancy really makes the screening process more valuable and more understood from both parties. And so I think you can collect SDOH data at the beginning as you're going through a patient's emergent issues, but then maybe put some of those questions on the back burner for later in the patient's stay, so that while they're in the hospital in their room once admitted, they've got a little bit more time and headspace, and then you can go back and do a more thorough SDOH interview, which would maybe go in depth in other areas. So it's appropriate for where the patient is at in their stay, and it's something that you might call a progressive screening.
So there were a couple of things you mentioned there that I thought were very insightful, and the frustration, of course, but frustration in this case is almost shared because the providers are also feeling it as well. And the structure that supports the use of the SDOH screener is in many ways as important as the screener itself. How can we use the data responsibly and steward the data if we're not collecting it and compiling it and using it responsibly as well? The hospital environment is very complex, and adapting new things to the hospital environment sometimes can be difficult and can be a process. But also making sure that process supports the way the patient is thinking about this and putting them in a way where they're comfortable. I think that progressive screening perspective is a valuable one there. Thank you for your input.
Great, thank you, Kevin.
And if we could grab one more, please.
And Maria Wyatt Hobbs. Okay, I guess we don't have any responses from her.
Excellent. So just to agree with the perspective in the chat, absolutely. And of course, we can see that a patient with experiencing tachycardia and experiencing hyponatremia, very often there's a nutritional aspect to that. Now, looking at our case, just to dissect it, this case is based on many experiences at a community hospital and my own frustration. And in speaking to colleagues, this is not an uncommon thing. It's the result of an adaptation to our existing structure that is evolving and changing as we learn to bring SDOH concerns more into the existing hospital framework and outpatient framework. Looking at this individual, we have someone with two very serious medical conditions, type 2 diabetes and chronic kidney disease. These are life-threatening, and they very seriously impact their ability to live their daily lives. Now, if we can imagine that individual also having SDOH stressors, well, a syncope is a predictable outcome of that situation. Looking at the SDOH screener, many systems struggle with when to put their screeners in the workflow process. It's a question that is often frustrating, and at times institutions can either overuse or underuse screeners based on individual dynamics in their system and their work and patient care needs. This individual had a screener at the beginning of her ED visit, during her inpatient stay, and at the end of her inpatient stay. What's clear there is there's lack of an organized framework to discuss it, and there's lack of an organized framework to input the data, analyze, and use the data. In circumstances like this, where an SDOH screener is done on 3 different occasions in a single patient, well, it's likely that each individual that did that screener had no inclination that other people had done a screener or were planning on doing a screener. The next slide, please. And to look at the follow-up visit. It's very clear that the SDOH concerns are exacerbating existing chronic illness, and this is an opportunity to link someone to social services. The individual is linked to social services, but the screening process is the beginning of this process. And if an individual experiences frustration or shame, it can lower their chance of following up with those resources. Focusing the screener in a place that works and focusing it in a workflow that communicates well is an important aspect of increasing patient trust and increasing follow-through on those resources. And if I may add, also lowering burnout and frustration in our very valuable frontline staff. Next slide, please. Or next slide, please. Thank you. Looking at the structural implications here and the structural limitations of this, this institution, if we consider a rural community of approximately 50,000 people in a small community hospital, small community hospitals who are not part of larger systems at times are limited in how they can adapt to local needs or or put screeners into their action plans and workflow. Considering that, though, there are ways that institutions can evolve and change with the evolving needs and resources that are now available. So some structural limitations that I think are worth emphasizing is one, a lack of organized framework dictating when the SDOH screener is performed results in overuse of screeners. When a screener is instituted, having firm policies of when it's used, how the data is used, and how the data is collected and managed is extremely important and a constituent element of doing this responsibly. It also presents opportunities to involve community members and community leaders in the use of that data. This is very sensitive data, among the most sensitive one can share. And involving community leaders in how one collects and uses that data can be very helpful in increasing trust specifically in both the process and the stewardship of that data. It can also be an important source of innovation as well in where to go with that process. 2, poor systems for tracking SDOH screeners result in duplication of efforts and limited ability to compare screening results. This is in many ways a financial question as well. Staff time is limited and staff time is expensive, and duplication of efforts can result in lost revenue in addition to frustration and patient care dynamic concerns. Another reason to ensure that when screeners are used, they're used appropriately and they are studied very closely. It can save patients and it can save money in the institution as well. And 3, multiple screeners result in fatigue in staff and patient, limiting resource navigation at key instances in the patient care continuum. When individuals are in the ED for a chronic disease, SDOH fusion, let's call it, this is an opportunity to link them to resources in a very, very vulnerable time in their life. But much like doing a procedure on a patient that's experiencing an illness, linking a patient to care when they're experiencing an illness can be difficult as well. And those considerations should be prioritized when planning, implementation, and evaluation of screening efforts. And for the resources, if you consider how many patients go into a community hospital and the duplication of efforts, we're possibly talking about hundreds of thousands of dollars a year in wasted time that could be used doing other things. Evaluating how screeners are used and in not just SDOH, but anything, is a great way to increase the efficiency of your workplace and notice and identify redundancies. I've never met an institution that doesn't have a redundancy somewhere. It's just a natural byproduct of people working and making institutions. And a reflection on that at a quarterly or yearly basis is an appropriate structure that you may find helpful in improving the efficiency of your institution and improving the experience of your patients and your workers. Next slide, please. Just briefly to look at our formats again. This is an outpatient application in which the screener is done at intake and it is done at follow-up. At intake, the screener gives key information that allows networking to resources at that time. During follow-up engagement, a second screener done appropriately allows assessment. When the patient is doing the screener, they should know how that data is being used, and communicating why that data is being used and how it's helpful is a great way to improve collaboration with your patient and improve their likelihood of a successful outcome. People respond very well to coaching dynamics, and many studies have looked at coaching dynamics in CHWs and shown that they're very effective in imparting behavior change and encouraging behavior change. Please take this into consideration when you're looking at evaluating and implementing SDOH protocols at your institution. Next, in the inpatient environment as well. Similar process, different environment. Next, please. In the interest of grounding our session in the pragmatic realities of SDOH program implementation, let's examine a helpful case study and then translate it to our own contexts. The WellRx pilot at the University of New Mexico gives a perspective of thought and management processes that are behind successful design and implementation of SDOH screening. Essentially, the Office of Community Health at the University of New Mexico in Albuquerque that oversees this outpatient system had a longstanding interest in integrating SDOH into ambulatory care. That longstanding interest was present through employee education, learning, and executive discussions at the administrative level. In 2012, they received a grant to create an SDOH screener and implement it into their outpatient clinics. They took 3 family medicine clinics and they implemented the screener at each institution. They gave each institution paper screeners, and they allowed them to integrate it into the workflow in whatever way that they wanted or saw as most appropriate. Next slide, please. Now, the WellRx pilot is interesting and insightful because it shows how an institution can take screeners, available screeners, and adapt them to their local needs. And in doing that, stay firmly within the framework of what research has validated and how appropriate patient care has been defined by physicians and nurses groups throughout the country. Essentially, if you look to the left, we can see the results of their screener. They took 3,000 to 4,000 patients and screened them initially using the screener. This was part of the pilot. What they found was the following. In this particular community, it seems that utilities and income are the primary SDOH concerns in the patient population. But as we can see, there's a variety of them. Compiling screening data in this way allows you to take a look at what your patient needs are and your availability of resources are. If I was in a position where I saw a screener result like this, and I took a look at the available resources in or around my institution, I may decide to form new partnerships or expand resources in key areas based on this. I may also choose to put employees focused on certain areas of SDOH based on this. It's a very powerful management tool and very powerful in helping workers feel more engaged and effective in what they do and making patients feel more cared for and happier. And to briefly talk about their process. In the WellRx pilot, there was an existing institutional interest in the SDOH. This can happen in the institutional interest in SDOH and in improving that aspect of patient care is a necessary step to implementing these policies. And realistically, the more you can develop that at your institution, the better results you'll have in finding ideas and practices that work appropriately for your patient population and improve outcomes and dynamics at your institution. In this case, the OCH team reviewed existing SDH screening tools, which we'll take a look at in a second. They prioritized ease of use and use of an appropriate literacy level. They chose to keep their literacy level low and in order to capture members of the community that had low levels of literacy. But that may differ depending on what your community is and what the understanding of the English language is. Involving screeners that are in different languages may also be appropriate depending on your community demographics, outcomes, and language needs. What they found was what many of you may have found in your own efforts, that no single tool met their criteria and also captured the SDH concerns that were important to their community. Existing tools were either too lengthy, narrowly focused, or population specific. To create the screening tool, the team developed a preliminary SDH domain list based on stakeholder input and their experience as physicians and researchers. When doing so, designing a process so you can get community input appropriately through discussions with patients in an organized fashion, through focus groups, involvement in boards of advisors, or so forth, is a very important tool in being able to form your screener appropriately. They also chose to make the items as simple yes or no answers to allow quick compilation of data and quick analysis of the data. This was particular to their situation, and you may find that using a more lengthy SDH screener or an SDH screener that uses something other than yes or no questions may be appropriate. Next slide, please. Now let's look at the screener itself. This is, for those of you joining us for the first time today, each of the slides with a resource will have a link to the resource. It will have the full resource and the article attached to it. I recommend taking a look because there are many details in these publications that may be particular to your institution and may be particularly helpful. So let's look at the things they chose to put in. In the past 2 months, did you or others you live with eat smaller meals or skip meals because you didn't have money for food? Are you homeless or worried that you might be in the future? Do you have trouble paying for your utilities? Do you have trouble finding or paying for a ride? Do you need daycare or better daycare for your kids? And these are all yes/no questions. Now, the benefit of this is that SDH screeners are time consuming. And if you need to do them quickly within the patient care visit, then a yes/no may be appropriate. However, in other circumstances where you may have a more in-depth consultation with the patient, or there's more time to work with the patient through the screener, it may be more appropriate to do longer answers that give you more details and more specific details. If you look at these questions, the authors are being very specific about the specificity of their questions. They are being very specific about how they're talking about food and the availability of food, and they're keeping their questions as simple yet complex as they can at the same time. This is very difficult. And a process I would recommend is to keep the language simple, yet prioritize the areas that are very important for you to get data from. For example, well, actually, if we go to the next, please. And here's our next. They ask questions on employment. Do you have employment? Do you need help finding a better job? You can envision the resources that may be associated with these questions. Do you need help getting more education? Are you concerned about someone in your home using drugs or alcohol? Do you feel unsafe in your daily life? Now, In considering these questions and resources, Fide, I'll ask you to put on your patient hat for a second. If you were to answer a screener and there were questions that you said yes to, for example, you needed more education or you needed help with unemployment, and the social worker did not follow up or address those, how might that affect your experience as a patient?
Well, as a patient, I think I would struggle with trying to, of course, find my resources that would be available to be in my community, in terms of finding employment or seeking help on where I can expand my education. I think that would provide like some limitation for me as a patient.
Do you think your trust would be impacted if you answered on several occasions a question that you needed something and it didn't even show up in the conversation?
Yes, it would be.
Social work and CHW work is very difficult, and the individuals that perform these jobs are limited by the frameworks that and protocols and policies that they need to follow. Putting someone in a position where they're doing a screener and asking a question that they don't have the ability to follow up with has two outcomes that have been researched fairly frequently. And one is it causes burnout in the individuals asking the screening, because it's very clear to them that this is something, there's a limitation that they have that they cannot fulfill. And also it affects the trust of the patient. When a question is involved in the screener and put into the screener, that's a process that involves, one, looking at what you do with the information. Are you using it to link that patient to resources? Are you collecting it to develop those resources? Be careful in putting questions into screeners that can't be directly translated to action for the patient. It may result in decreased trust and decreased involvement in the screening process from both the patient and the worker. Next slide, please. Now, based on reading this case study and 6 others that were done in similar organizations and similar contexts, I wrote down a framework that I think helps clearly describe the process and can be adapted to local and community use in the very diverse communities that we all serve and live in. We can also take the WellRx pilot and the case studies in this publication and use them to adapt those frameworks for implementation. In particular, examination of multiple examples like this allows us to determine that general structure. And to start from the beginning, the first step of improving movement towards SDOH policy integration, and this is a process, many times a multi-year process, the initiation to invest in an organization culture that supports SDOH is a very important constituent element of that. Some ways this can be done is 1, increasing diversity of staff and leadership. 2, improving access to employee ideas and entrepreneurship through inclusion of staff in advisory boards and feedback sessions. Increasing access of community members to positions of influence within your organization is also quite helpful. That can be performed through interviews, through involvement in coordination in advisory board committees, or by other ways as well. Depending on the makeup of your community and the individual cultural dynamics in your community that are important to you and your community, different processes can be appropriate for different organizations. My recommendation is consider the options carefully and discuss it with your colleagues and community members. Now, screening and tool adaptation. The research and literature indicates that communities should adapt SDOH screeners in order to meet their community needs. The process we've discussed, but there is literature available that breaks it down in much more detail if you follow the links in the resources I just covered. More detailed and reviewed in this lecture. For those of you who'd like that detail, I'd recommend opening that up and taking a look. You may find that individual case studies have more insight to your own community than you might have thought. Funding and financial health is an important aspect of increasing SDOH care in your institution. In particular, because many professionals that perform screeners and do SDOH linking to resources are not reimbursable by conventional means. Funding and financial health can be supported in a couple of ways. Many folks get grants, and grants are, of course, a very important fix to this. But you may find when looking at your institution's workflow and its use of staff in key positions that you may be able to find efficiencies in your own institution to increase screening and proctor screening without having a significant cost to your organization. You also may find that improvements in efficiency and well-being in your organization's worker pay off that investment quite well. There is data to suggest that. My suggestion is to look closely at your organization's needs, consider the literature, and make the decision that's best for you. Integration into workflow is an area that is quite complex, depending on the nature of your institution, inpatient, outpatient, the makeup of your community. It can be even more complex. For those of you who are looking at SDOH program expansion or initiation, my suggestion is to make flowcharts or write or in any way that helps you to conceptualize your organization's workflow and to find key areas where these things can be improved, and to do that in the context of a discussion with colleagues and community members. And of course, pilot and evaluation. The pilot is just the first start. Initial evaluation after a pilot will help you to know what was effective and what was not, and the next steps in making a program permanent. Next, please. I'm going to briefly go over some resources that may be helpful in helping you to expand SDOH program at your own institution, if that's your focus. This publication in particular is best that I have found validating the adaptation of screening tools in clinical context. Folks have reported that at times hospital and healthcare administration can have trepidations in adapting screener use. Thomas Heckel validates the community adaptation of screeners, and you may find it helpful to make this available to colleagues, administrators, and decision makers at your institution. Next, please. I had a consulting appointment with a health center in Michigan this week. This individual mentioned that they may have funding coming in Michigan for CHWs. If there are any individuals from the state of Michigan, could you please raise your hands? Do we have any folks from Michigan?
Nope.
Okay. So the new bill in Michigan, and I'm not too familiar of how in Michigan state law works, but in an understanding how it works in my region, and taking a look at the state resources on this bill, I was very excited to see that in Michigan, CHWs will be funded through a combination of federal and state funds with no geographic limitations, so statewide. This will be statewide, and the bill has been passed, and there is a structural timeline for implementation. I included this because it's yet another sign that institutions should be prepared for changes in healthcare business and facilitate larger CHW workforces. For years, we've been hoping this change would happen. The Michigan bill is not unusual. There are bills going through state legislatures throughout the country that are similar in composition and in preferred outcome. Considering that, and considering that we may be in an environment in the future where CHWs are reimbursed, and that may be sooner rather than later, depending on where you live in the country, it presents a problem that I think has an important solution. Institutions that can maximize the use of their CHWs now and find efficient and effective ways to motivate and utilize their CHW workforce will be prepared for these changes when they happen. My suggestion is to keep an eye out for developments on these changes and to be active in contacting your state representatives and officials when these are up for vote, if it's something you support. And next, please. I'd like to finalize the session by focusing on employee burnout. There's a wide variety of scientific studies and literature that look at burnout. And what we found that is in recent years, research that looked specifically at SDOH burnout and how the feeling of not appropriately meeting patient needs affects the psychological well-being of clinicians and administrators. I kind of put this in because it's a chart of one of my own past frustrations. So at a hospital, a community hospital, if a nurse wanted to implement a change in the electronic health record, they would need to go through this. They would need to tell their nurse manager, their ICU director. ICU director would need to talk to the hospital administration. That would need to go to the IT manager, the IT staff, and then there would need to be training and implementation. Now, I place this for several reasons. One is to give insight into how complex decision-making can be at healthcare institutions. Now, they're complex for a reason, and I believe in many cases those are very good reasons. But there are many ways that institutions can improve access to employee ideas and employee entrepreneurship by having advisory boards that include employees, by delegating key tasks of program development to employees and staff. You may find that depending on the makeup of your workforce and staff, it may be appropriate to find new ways to get your institution to share these ideas. Because at times a circuitous or difficult communication method within your institution can translate to frustration on the employee level, and that contributes to burnout and retention issues. My suggestion is to look closely at your system decision-making tree and to consider if there are ways that it can be improved or be made more effective in ways that meets your institution, patient, and workforce needs. Next, please. The Physicians Foundation performed a study in 2020 looking specifically at burnout for SDH. And the results were, to me, very shocking. The 6 in 10 physicians have little to no time to address the SDH in the exam room. 89% indicated lack of staff to address the SDH. 8 in 10 physicians believe not integrating SDH into care contributes to burnout, and 6 in 10 report burnout when addressing SDH. Now, these are reports of physicians. Let's look at some other data. Next, please. This study, the capacity to address social needs affects primary care clinician burnout, was a study that looked specifically at burnout in primary care physicians, and it didn't just elicit their opinion, it measured the burnout through psychological measures. It's a very powerful and very insightful study, and I'll briefly go over some of the main points. One, SDH burnout impacts clinicians' abilities to meet patient needs. Burnout can affect how clinicians evaluate their clinic resources to address social needs, with clinicians reporting high emotional exhaustion and perceiving low efficacy even when the resources are available. SDOH burnout has severe impact on clinical emotional health and well-being. Unmet social needs affect practice by influencing clinic flow, treatment planning, and clinician emotional wellness. As many of you may have experienced in your own practice and clinical careers, or in your work at health centers that are non-clinical and positions that are non-clinical, is that burnout has a very real effect on how we do our job and can be very impactful in our own mental health, our private lives as well. Social services in PCP clinics are protective against SDOH burnout. That's a very important point to sort of emphasize here. By putting those SDH resources in the clinic, and by making staff aware that that is being done, and the awareness is a very important part of that. You protect your staff's psychological well-being, and protecting your staff's psychological well-being can result in healthier patients, and it can result in less turnover. Clinicians see in-clinic social services as effective, but insufficient to meet patient needs. And I felt that as well. SDH and SDOH concerns should be addressed in the clinic, but they need to be continually addressed out of the clinic as well. For those of you who come from institutions that integrate and utilize person-centered healthcare delivery models, your own experience in seeing that should add credence to that. Next, please. So we have reached the end of our LC. This is a quickly and very rapidly developing field. It's been a pleasure to be able to go through the new resources and to share those with you. And I appreciate your insight and participation throughout this whole session. I know I certainly learned a lot about your working lives at your institutions, and that gave a lot of insight into how I consider my own TTA and my own position here. So thank you. Also, thank you all for your service to your community and to the communities and to the vulnerable positions there. Keep an eye out for our future trainings. I'd love to have all of you again. For the purposes of supporting your institution's development, our organization is available for consultations and help as needed to provide validated tools, and analysis that may be helpful in proctoring your SDOH program implementation, performing evaluations, or supporting your staff and yourself emotionally as you go through this very difficult process. The SDOH are very emotional subjects. It's a very emotional subject. It ties very deeply to some of our deepest frustrations and concerns as clinicians and administrators. And what you may find is that integrating the SDOH more as a framework and more as a way of understanding can greatly improve the wellness of not just your institution, not just your patients, and not just your workforce, but yourself as well. So thank you all for your participation, and I'll accept any questions, concerns, or comments at this time.
Thank you, everyone.
Sorry, I just wanted to say thank you to you guys for everything you're presenting, because it helps me take a second look at everything to see if we're doing things right, because we piloted over we're coming up on a year, and we started out small with ways we knew we could be successful, and then we're gradually adding on to it to try to expand. We're up to 8 categories now that we generally have resources that we know we can get to, which helps with the burnout in the clinic, because then our people who are doing the actual screening were able to chart and note the results, like what's going on with the patient. And so when they see them again, that's in the note, and then they can also follow up on that and see if they need to be back referred. And having our providers refer to our people who are working kind of like CHWs, even though we're not, having that referred that way allows us to continue the follow-up on it on our end, but also to update the rest of the team so that when they see the person again and they're asking these questions again, that they know, oh, well, you needed help with food, and it looks like you've gotten that assistance. Is that working? So they get one more time where they know they're cared about and that it's being worked on, and the team is learning to do the follow-up on that as well. We're trying to make it a whole, as you said, culture inside of our facility. So I just want to tell you thank you, because I get some good ideas from this, and thinking about that, not going too crazy on how many of them we're working on, and by building, we're not getting that burnout because we're getting success out of it. So then they're more willing to add more and work harder to get those taken care of as well.
Well, thank you for that, Susan. If I may add, just based on what you mentioned earlier about the responsibilities in your position, and having met a fair number of people who fulfill your role in similar communities, it's very difficult to do all of those things and to do anything else, let alone, you know, do a complex program design and implementation. So I guess I'm saying that to say excellent work, and, you know, take the credit where it is due, and to say to offer to please reach out. I'd be happy to provide resources, assistance, analysis, or consulting in any way that helps you. And of course, that's a service provided to health centers by the National Center for Health and Public Housing. So please don't be shy. We'd love to hear from you.
That sounds awesome. Thank you. Because we are really trying to hit all those spots. So yeah, I very well most likely will be reaching out to you.
Well, just send me an email and we'll schedule an hour consultation, and FIDE and I will do whatever we can to support you. And that goes for everyone as well.
Perfect.
This is very difficult work, and if we're going to do it, we need to do it together.
That's fantastic. Thank you, Kevin, and thank you, FIDE, as well. You guys are great. Thank you so much.
You're welcome.
Thank you.
Do you have any other questions or any feedback you would like to provide to us at this moment? Okay. All right. So this
Well,
is
thank you all for your service. Sorry. Thank you all for your service. I look forward to seeing you. FIDE?
I just wanted to remind everybody that at the end of the session, to please complete our post-evaluation survey. In the survey, you're going to see that I have added a few other questions where you're going to be able to provide your feedback about the LC as a whole. So your opinion and your feedback is very useful to us. That is also going to help us tailor any future trainings, and that way we can better serve your health center or organization.
Thank you. Goodbye.